Dr. BMS viewers, welcome back to our channel. A listener of our channel recently asked me, Doctor, how do you deal with patients who are resistant, especially when they get into your center? They are defiant, some of them are showing signs of shame, guilt, and generally the negative characteristics associated with resistance to rehabilitation. This is what I want to talk about today so that we educate the public out there and at the same time spread the message of rehabilitation, which we need when we have a problem like addiction to alcohol and drugs. Before we delve into it, as always, I remind you, if you have not subscribed to our channel, share these videos with a friend of yours, spread the message so that our channel grows, the awareness grows, and we have a healthy society, body, mind, and soul. So today I would like to talk about how we deal with shame, guilt, and stigma in rehabilitation as part of the resistance that the patients may show when they come to us. This is a common thing in rehabilitation because most of the people who come into rehabilitation have been coerced into it one way or another. And we've said before that people get into abuse of alcohol and drugs mainly by accident. Nobody goes to enjoy a party, a good moment, they take alcohol or smoke weed, feeling like they'll get addicted and they'll become sick from it. It comes as a consequence without them intending. So a number of them experience shock when they're told they are addicted or when they realize they are addicted, and some of them deny this and persist in that denial long enough to come into rehabilitation still in denial. And as the denial manifests, you may find also other aspects of denial, of resistance, like shame, guilt, stigma, which is the topic for today. So why then do people feel shame, stigma, guilt? Why do they get into denial when they are in rehabilitation or when they have been told they have a problem with alcohol and drugs? There are many reasons, but I could distill them into three main categories. The first is something to do with the patient themselves. I would say their ego, how their self is made. And some people have got big egos, strong-willed. They believe a lot in their powers, their infallibility, their prowess. And so as they go out partying and enjoying themselves, they feel everything will be okay. They're in control of their lives and things will be fine. And then when things get out of hand, they're shocked that things could get out of hand. Otherwise, they shouldn't, because I am strong, I'm in charge, I know what I'm doing, I'm some Superman of sorts. That's your ego speaking. That is that strong will you have. And because of this strong will, you may find these patients again resist the assertion that they have a problem, the reality that they have a problem, the diagnosis from the doctor or from the family. So they come with defiance, and that defiance may manifest as shame, guilt, denial, and all other forms of resistance that we have discussed. So the strong will of the person may be in the way of them accepting there is a problem, and as a coping mechanism, they may move from denial, open resistance, to feeling ashamed because of their ego, their strong will, which they feel has been belittled by what has happened. Another category of patients we get are patients who come with, say, mental health problems. This patient has like depression, low self-esteem. They don't feel their worth. And so in this low mood, depressed state, low self-esteem, you find shame, guilt, and negative self-assessment coming as a result. And this can explain why these things manifest. The third broad category is usually the interaction between this patient and their family, the society, the societal norms, expectations, the culture, the way of life of the family, the social networks around this person. So as they sink into abuse, addiction of alcohol and drugs, if the norms, the societal expectations are contrary to that, then people may point fingers at them. They may judge them. And these people will start feeling they are unwanted, they are not fitting well, and with it, the feeling of shame, guilt, and other forms of resistance may come as a result. So, whichever of the three driving this process, whether it's single, sometimes it could be a combination of more than one. When they come into rehabilitation, we have to deal with this. And that's the discussion today. How do we deal with it? The first thing that we do is to recognize that this problem is there and diagnose it well. Like, this patient seems to be in great denial. Some of them, it could be open hostility towards the program. I want to leave, I don't want to stay. And some of them could be silent, they are withdrawn. They don't interact with others. They feel embarrassed, ashamed, they feel guilty, they blame themselves. And some of them may even have thoughts of self-harm. Okay, I'm not worth, maybe I should just not live because of what I've done. I've ashamed my family. So you recognize that there's a problem of this nature with this patient, and then you diagnose it by broadly looking at those three categories and see what is driving this behavior. Is it because of the strong ego that this person has naturally, which has been hurt because of this behavior? Is it because this patient has got a mental problem, mainly around depressive illnesses, problems with the esteem? Or is it because the family, the society she comes from is driving this because they highly disapprove of this, and so he or she is feeling like an outcast? Once you have diagnosed what you think is driving this, then you move to alleviate it, to deal with it. And the first thing we do in our center is to create an environment that enables this person to fit in, to feel welcome, to feel not judged, and to be able to express themselves so that they affirm the diagnosis that we have seen, that probably it's an ego thing, probably it's a mental health thing, probably it's a societal thing. And so we create an environment in our rehabilitation center where we have open and judgmental communication. Our patients, when they come in, we make them feel that you've not come here to be judged, to be blamed for what has happened. You have come here to be helped to think through it and to find a way to rectify it, so that when you go out, you go a new person doing new things, and that is what rehabilitation is. So creating that environment, right from the counselors, the doctors, Dr BMS and the others who are dealing with these patients, down to their peers, so that they are in one group, a family where everyone is loving, everyone is non-judgmental, everyone is listening, everyone is empathetic, and everyone's voice matters. So then from this, the patients start slowly getting out of their cocoon, out of their shell, and they feel they can talk, they can associate with the others, tell their stories without feeling judged. And as they start to express themselves, then they start also fighting, reducing this feeling of shame and guilt, because they see like there is hope. We can get onto better things away from just locking in yourself and feeling like you are worthless. Alongside that, we start as early as possible a program of education. We call it psychoeducation, and this is education that is aimed at replacing notions, myths, beliefs that may exist about alcohol and drug abuse, which are not helpful to recovery. And so, at the core of it, we make the patients know that addiction, abuse of alcohol, drugs is a disease. So you are someone who is unwell, just in the same category with a patient who has malaria. So you're not different, and it's not because you are abnormal, you brought this to yourself, you are cursed. No, you are someone who has a problem of not being able to control their usage of recreational drugs well, and that is a disease. And so the education then replaces the myth and misconceptions which sometimes drive the stigma, drive the shame, they drive the guilt that the patient may experience when they have not known better. We, at the same time, employ or put in place therapeutic aids that help us to make these patients comfortable and heal better. What is commonly called medically assisted treatment or therapy, medically assisted rehabilitation. I mentioned that some of them may be having this feeling of guilt, shame, denial because of mental illness, for example. And so if we diagnose this to be a problem, then we will come in with medications, psychiatric medications that can help combat these mental illnesses. And we have a variety of mental illnesses that are common in people who are abusing drugs. I mentioned depression. Some of them will have bipolar, a mood disorder. Sometimes they are really on a high mood, sometimes on a very low mood, depression. Some of them may have attention deficit disorders. These are people who cannot settle into any task and complete it. They are always restless. They start, they stop. Their concentration is not good, and so tasks are uncompleted. Some of them may have suffered trauma in the past, and that trauma prevents them from settling in life and in things long after the trauma has gone, what is called post-traumatic stress disorders. So we've got a number of mental health illnesses that can be diagnosed in these people, and if they are treated well, then the manifestations of shame, guilt, low esteem, denial will start to minimize. So we employ medical therapies to help along the way. Counseling is also part of these therapies, that these people may have psychological problems within themselves, with their families, at work, and with the general society. And we want to know what this is and help them work through these problems in a healthy way so that they come out on top, and that is part of the rehabilitation. As we do this, we set goals. Goal setting, so that when the time you leave the rehabilitation, you have a good idea what you're going out to do, how it's gonna be the new life after rehabilitation. And so as they come in, we would like to know what they have been doing, what they have planned to do, even if they did not succeed in the plans before. We bring in the family to assist us in this planning, to support the plans that are made, so that as we set goals for rehabilitation and goals for after rehabilitation, then this patient starts to settle in, feeling like there's hope. Things are now changing, there are new things in the horizon, and there are things to look forward to, and that takes away that feeling of despondency, low esteem, which I said would be the drivers of shame and guilt and stigma in these patients. We encourage, as I said, family to participate. The aspect of family participation is also very important in combating shame and guilt in these patients, combating denial, because as I said, it's one of the things that could be causing the problem in the first place. If the family's expectation, norms, the culture around the society, the family live is saying that you feel unwanted, an outcast, and that's what is driving your behavior, your addiction to alcohol. Then when the family is brought in with the education that we've talked about, the psych education, with the counseling that we have talked about, with the goal setting that we have talked about, and generally discussing the dynamics of the family relationships with the patient and other people in the family, then a new way of thinking emerges, a new way of relating emerges within the family, and the patient gets an opportunity to discuss, to express themselves, what they felt when they were out there before they came into rehabilitation. And then we create new ways of thinking, new relationships. If there are past hurts, past problems that were preventing these people from moving forward in a positive way in their life, we talk. So it's like truth and reconciliation of sorts. And then these people live when they have a new understanding, a common ground, and new projects to work on together to help the person who is in rehabilitation and is recovering from addiction. So in a nutshell, those things plus the time spent with us, we say rehabilitation is not a touch and go thing. You need to spend time in it. In Kenya, as we said, a minimum of 3 months, but we even encourage longer than that. So that time spent in that environment that is enabling you to see things differently, with the education, with the family coming in to discuss, to deliberate things differently from in the past, over time, the patient starts to change. The feeling of shame, guilt, the stigma around their past and their behavior starts to disappear, and new hope starts to form, replace where the stigma, the shame, the guilt was. And this is the rehabilitation process with regard to patients who are in denial and feeling negative about themselves and being in rehabilitation. See you again in another educative video of Dr. BMS.